Scabies, despite being one of the most common dermatological infestations worldwide, it still remains frequently missed, misdiagnosed, and mistreated. Today, we will discuss not only how to recognize scabies accurately, but also why a disease caused by just 10 to 15 mites can make an entire household miserable. So let's deep dive into the topic. Starting with a brief morphology of adult scabies mite. So the color of the mite is creamy white and it is ovoid in shape. It is dorso-ventrally flat. The dorsal surface of the mite has transverse corrugations and a lot of spines. These are spines. It has 4 pairs of legs. The anterior 2 pair ends in suckers and the posterior 2 pair ends in setae or bristles. The mouth has 2 cutting structures, chelicerae, and adjacent to are openings of salivary glands to dissolve the human skin. The dimensions are: the length is 0.4 mm while the breadth is 0.3 mm. This is for female mite. The male mite is half its size, that means 0.2 into 0.15 mm. In males, the anterior 2 pairs of leg ends in suckers like in females, but in the posterior legs, the third one ends in bristles and the fourth again in suckers. Discuss the life cycle of Sarcoptes scabii var. Hominis. This is a gravid female and she lays eggs until she dies at a rate of 2 to 4 per day, and in total 40 to 50 eggs. These eggs are 0.1 mm in longest diameter or maybe 0.15, and after 3 to 4 days they hatch into larval stage. These larval stage are 6-legged. They have 6 legs. Adult had 8 legs. The larval stage move on the skin surface and dig small shallow burrows where they molt into nymph. The nymph has 8 legs, almost a smaller adult but who can't reproduce. So in nymph stage they molt again 1 to 2 times into protonymph and deutonymphs, and this stage lasts for 3 to 4 days. After 1 to 2 molts they become an adult mite. So from egg to an adult mite it takes around about 10 to 14 days, about 2 weeks. Now adult male and female mate on the skin surface or maybe shallow burrows. The male die after mating. Now the female becomes gravid and they again dig a deep burrow to lay eggs. So the lifespan for an adult female is round about 4 to 6 weeks or even 2 months. These mites are obligate parasite and outside human body they die within 2 to 3 days due to dehydration. Apart from the agent factor, there are some host factors like poverty, malnutrition and immunosuppression, and environmental factors like overcrowding as in camps, hostels, prison and hospitals that leads to easy infestation by scabies. Before starting, we should know what is Circle of Hebra. The sites of predilection to dig a burrow or the scabies mite infestations are the wrist area, the elbow, the anterior axillary fold, the mammary area, especially the periareolar area. Again on the other side, axilla, elbow, wrist, and the groin and the crotch area, periumbilical area. So when these sites are joined, it forms a circle which was named after von Hebra, who described this circle. So this is a case of classical scabies, and he complained of pruritus, and you can see all the classical points of Circle of Hebra is involved with excoriated papules and eczematous lesions. The incubation period is around about 3 to 6 weeks. If there is a case of reinfestation, the symptoms develop within 48 to 72 hours. The classical presentation is nocturnal itch because the mites are more active and the patient is also a bit in leisure to notice the itch. Classical lesions are burrow. Burrows are pathognomic, though it is very difficult to find, and usually they are found in the penile shaft. The excoriated papules, vesicles usually in infants. Vesicle is also present at the end of a burrow in a classical scabies. You can have persistent nodules, itchy nodules even after treatment, and there is sometimes bullous lesions as well, especially in. So the secondary lesions are excoriations. You will see excoriation marks, eczematous and lichenification. Complications severe urticaria, and there can even be PIH in secondary lesions. So complications are urticaria, eczema and impetiginization. If it is not treated properly, this bacterial infection may lead to infection in the kidneys presenting as acute PSGN and to the heart presenting as acute rheumatic fever. Prolonged physical contact, usually about 20 minutes, is needed for transmission of scabies, but as little as continuous 5 minutes has also been seen to transmit the infestation. But a casual hug or just bumping into someone doesn't usually lead to transmission. So this is an infant presenting with papules erythematous, papules excoriation marks, and excoriated papules diffusely all over the body, including the abdomen, the thighs, the legs, the cubital fossa, the webs of fingers showed a lot of lesions, the feet, and even the cheeks. This was being treated as atopic dermatitis, which is a very close differential of, but when we examined the mother, we got erythematous papules and excoriations over the periumbilical region. So this was a case of infantile scabies. Thing to remember here is that the face, the hands and feet, even the palms and soles and scalp can be involved, and you have to look for a family history. Then there is nodular scabies. There is persistent small nodules, especially over the groin and the penile shaft, scrotum, axilla and periumbilical region, and these are persistent even after treatment. Remember that itch persists for about 1 to 2 months even if you treat the scabies with appropriate treatment. The mites die, but since it is a hypersensitivity reaction, the itch remains for 1 to 2 months. Sometimes there are bullous lesions as well, the bullous scabies resembling the bullous pemphigoid. There is scabies incognito, similar to tinea incognito, where there is high degree of suspicion, but the typical signs and symptoms are absent. Now there is something called animal scabies. Here, if you have a pet and who is infested with scabies mite, the mite is Sarcoptes scabii var canis in dogs. So the pet have the scabies, but so the areas in contact with the pet, like the hands, even abdomen, the wherever it comes in contact, you will get itchy papules. This is also called pseudoscabies. Here the treatment is self-limiting. If you treat the pet and give supporting treatment to the human, the caregiver of the pet, that is enough. So now coming to crusted scabies. Here we had seen a patient, Hansen's disease patient, but he presented with this rash which was not consistent with Hansen's disease, literally in erythroderma, with a lot of scaling. There is no history of itch, but we could see excoriations There was heaps of crusts over the palms, very hyperkeratotic. So this is the KOH preparation, and see how many scabies mite in a single field. 1, 2, 3, 4. Here also this is another field, unhatched egg with the mite. 1, 2, 3, 4, 5. So, and these are eggs. You can see Scabiella here as. So this now became a confirmed case because we could demonstrate the mite. The patient has millions of mites. The count is in millions. Again, this is another case. We got a call from emergency. The patient had altered sensorium because he was an alcoholic and he didn't complain of it. What we could see in examination is there was an ulcer in the scrotum and the scales of the hands were hyperkeratotic. There was fissuring. The webs of fingers were predominantly involved, even the inner thighs, and the scrotum had a large ulcer. So again we suspected of crusted scabies and we did a KOH slide, and this is what we got. Here 1, 2, 3, 4, again here 5, and we could see the eggs 1, 2, 3. So this was again a confirmed case of crusted scabies. Now this is an interesting case. Here the patient presented with this rash and no other rash, and he told that he had a surgery some years back and he got a rash over the surgical site recently. So he had predominantly here and here. These were the surgical site. The look itself suggested it seems to be scabies, but the situation was not very supportive. But what we could see, he had periumbilical excoriated papules on the inner surface of the forearm also he had. So this was suspected case of crusted but localized crusted scabies. Though we weren't sure, we prepared a KOH slide and we could. This is another case. The rash was only over one leg. It was secondarily infected and the appearance seemed to be scabies. Again, there was a history of flap surgery in the past years and we treated it and we got the this picture. After treatment, the rash has subsided and it was improved. So this is also a case of localized crusted scabies. So coming to the diagnostic criteria, it is by International Alliance for Control of Scabies 2020. A case is said to be confirmed only when you can directly demonstrate either the mite or eggs or the fecal pellets or scibala by either light microscopy or dermoscopy or other imaging techniques like confocal microscopy. What will you see? We generally do a microscopy or dermoscopy. So this is KOH preparation, and under a microscope we can demonstrate the mite. See, one mite is here, one is here, and one is inside the egg. This is unhatched egg. These are hatched eggs. These are hatched eggs, and here these are the scibella. Now in dermoscopy we can see jet with contrail sign. Here you can actually see the path of the tunnel that ends in the scabies mite, which might have a vesicle over here. Another sign is delta wing sign. It denotes the triangular scabies mite which can be seen in dermoscope. Most of the cases are not confirmed cases of scabies because there are only 10 to 15 mites in a case of classical scabies. It is easier to demonstrate the scabies mite in case of crusted scabies as in this case. So most of the cases are clinical scabies. In clinical scabies, any one of the following should be present: either typical burrows or typical male genital lesions or typical lesions in typical slides plus both itch and contact history. Many a times you don't get these typical burrows and the typical lesions in the typical sites, but there is very high suspicion of scabies, then it is called suspected scabies. For this, at least you should have typical lesions in typical sites plus either itch or contact, any one, or atypical lesions or distribution plus both itch and contact history. Now coming to the treatment of scabies. The classical scabies, one or more of the following can be used. First line, this is first line, is permethrin 5%. And it is FDA approved, but only above age of 2 months. So what can be used in infants less than 2 months? It is this sulfur. Infants under 2 months of age, sulfur can be used. Coming back to permethrin, these are synthetic pyrethroids. The natural ones occur in chrysanthemum flower. It should be kept for at least 8 to 14 hours. Though a single treatment is effective, but at least 2 treatment or more if required can be given 1 week apart. Now the next first line treatment is ivermectin oral. This is the only oral treatment available for scabies. It is not FDA approved, but it is widely used and it is recommended by CDC. The dose is 200 microgram per kg per dose, and it should be a weekly treatment. At least 15 kg of body weight is needed, and in pregnancy it should be avoided. It is recommended to be taken with meal to increase the bioavailability. Coming to the alternative medications, we have protomiton 10%. It is FDA approved, but the limitation is frequent treatment failure. Next is sulfur 5 to 10% composition in petrolatum. It should be applied for 3 to 5 days, nights continuously, and kept overnight for at least 8 hours. The major limitation is the greasy texture, the irritant smell, and the irritant reaction if it is kept for a longer time. So this sulfur is important with respect to that it can be used for less than 2 months of age. Next is malathion 0.5%. It is not FDA approved and there is limited published data. Newly FDA approved Spinosad, this is also topical, and 0.9%. So this becomes important because it is a new drug that has been approved in 2021. The last one is Lindane 1%. It is FDA approved, but it is toxic to the brain. So whenever it is required to be applied larger amount, that can lead to, like in premature infants, uncontrolled seizure disorder or crusted scabies with some skin conditions where the absorption will be high. It is avoided. Coming to the treatment of crusted scabies. In classical, either of the treatment can be given, but in crusted, both oral and topical agents should be used. So oral is ivermectin and topical is permethrin along with a keratolytic cream. So ivermectin, depending upon the severity, it can be given either in 3 doses, day 1, 2 and 8, or 5 doses, 1 to 8, 9, 15, or 7 doses, 1 to 8, 9, 15, 22 and 29. And permethrin should also be applied together with an oral agent. The frequency There is no consensus on that, but the recommended application is that every 2 to 3 days for the first 2 weeks. This is easier to remember. Now don't forget to advise on how to clean the environment. I try to bring conceptual dermatology in every class, and I hope I am helping a bit in every class. Happy learning. Meet you in the next class with a new topic. Till then, bye.